Welcome back, everybody, to part 39 of our IPDRG Masterclass. I'm incredibly excited for today's explainer because we are diving into what is, without a doubt, the absolute cornerstone of inpatient medical coding. We're mastering the principal diagnosis selection rules. Think of it like this. If you get this right, all the other pieces of the puzzle just naturally fall into place. But if you get it wrong, well, the entire reimbursement structure basically crumbles.
But real quick, before we get into the weeds today, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshul.
All right, let's do a super quick recap of Part 38 just to ground ourselves. Last time, we built out the fundamental architecture of how MSDRGs actually classify inpatient stays. We looked at how every single case gets funneled into one of the 25 major diagnostic categories, or MDCs, and from there, it gets partitioned down a surgical or medical path. We also saw how base rates are multiplied by a DRG's relative weight to figure out the final hospital payment. Basically, the higher the relative weight, the higher the reimbursement. Simple as that.
Here is our syllabus for today. We'll start with the UHDDS definition of a principal diagnosis, then break down the official selection guidelines, apply those to some real-world clinical scenarios, and finish up with a summary and a teaser for next time. Okay, let's jump straight into Section 1, the UHDDS definition of principal diagnosis. The Uniform Hospital Discharge Dataset, UHDDS for short, has a very specific definition for principal diagnosis. It is, quote, that condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. Now, I want you to mentally highlight, underline, and circle those two words, after study. Seriously, it is the most important phrase in all of inpatient coding. It means we aren't just looking at whatever the patient was complaining about when they walked through the front door. We're looking at what the physicians discovered, tested for, and treated by the time the patient was discharged. It's the ultimate hindsight is 20/20 rule. So you really have to understand the fundamental difference between the primary reason for admission and the principal diagnosis. The primary reason is just the chief complaint on day one. Imagine a patient walking into the ER clutching their chest, right? The primary reason is severe chest pain. But that symptom does not determine your MSDRG. The principal diagnosis is the condition established after study. So after the EKGs, the lab work, the overnight observation, the doctor determines it was actually an acute inferior wall myocardial infarction. That acute MI is your principal diagnosis, and that is what entirely determines the MDC and the resulting MSDRG. And this dynamic brilliantly illustrates how the admitting diagnosis is based purely on preliminary findings. The principal diagnosis, though, the one that dictates your DRG assignment and ultimate hospital reimbursement, that absolutely requires a full diagnostic workup and solid clinical evidence. If you make the mistake of just coding the admission symptom as the principal diagnosis, your MDC is going to be wrong, the DRG will be wrong, and the hospital is definitely getting underpaid. Moving right along to Section 2, the official selection guidelines. Let's open up the rulebook, starting with Guideline 2A, which deals with interlinked conditions. Sometimes you'll see a patient with two or more interrelated conditions that equally meet the definition for principal diagnosis. When this happens, you can't just flip a coin and pick one. You have to follow specific sequencing rules, which often means using combination codes. For example, if a patient is admitted for both hypertension and heart failure, we don't code them as two totally separate, unrelated issues. We use a combination code, like hypertensive heart disease with heart failure, to neatly capture the entire clinical picture in that one primary slot. Next up is Guideline 2B, comparative or contrasting diagnoses. This is a big one. In the inpatient setting, and only the inpatient setting, let me stress that, if a physician documents a diagnosis as either or, probable, suspected, or rule out at the time of discharge, we actually code that condition as if it were fully established. So, if the discharge summary says probable COVID-19 pneumonia, you code it as confirmed COVID-19 pneumonia. Why? Because it ensures that the high severity of illness and all those massive resources the hospital used are properly captured, even if a 100% definitive diagnosis was elusive. But again, absolutely do not apply this rule to outpatient coding. All right, Guideline 2C. This one builds directly on our core definition. If a patient comes in with a severe symptom, and the after-study testing reveals the definitive underlying cause, you always code the definitive diagnosis. You never just sequence the temporary symptom as your principal. Severe chest pain gets overridden by the acute MI. Shortness of breath gets overridden by the severe COPD exacerbation. The definitive diagnosis always wins. Finally, we have Guideline 2F, which covers a really interesting scenario.
What happens when the original treatment plan isn't carried out? Imagine a patient is admitted for a laparoscopic cholecystectomy to remove their gallbladder. But right after the first incision, the patient unexpectedly has a severe seizure. The surgeon immediately cancels the procedure to stabilize them. So what's your principal diagnosis? According to Guideline 2F, it is still the gallbladder issue. The seizure is a critical secondary diagnosis for sure, but it wasn't the reason that occasioned the original admission. Make sense?
Let's shift gears into Section 3, Clinical Scenarios and Impact. We're going to put these rules to the test.
Here's a classic coding challenge for you. A patient is admitted and the documentation states they have sepsis secondary to a urinary tract infection, or UTI. Both conditions were fully present on admission. So which one takes the coveted principal diagnosis spot? Is it the sepsis or is it the UTI?
While the official ICD-10 instruction here is completely explicit, if sepsis is present on admission and meets the definition of a principal diagnosis, the sepsis code absolutely must be sequenced first. The localized source of the infection, which in this scenario is the UTI, takes the backseat and is coded as a secondary diagnosis.
And looking at the numbers, the financial impact here is just staggering. If the clinical documentation is vague, or if a coder messes up and sequences the UTI as the principal diagnosis, the whole case drops into a much lower-weighted medical DRG. But by correctly applying the rules to sequence sepsis as the principal diagnosis, supported by physician query if you need one, you shift the entire MDC. Grouping this with a major complication like diabetic ketoacidosis literally doubles the DRG relative weight. You are directly protecting a massive amount of revenue that the hospital legitimately earned for the complex care they provided.
Let's look at Scenario 2. A patient is admitted with acute respiratory failure and an acute exacerbation of severe COPD. Both are life-threatening, and both are being treated aggressively at the same time. How do you determine which condition chiefly occasioned the admission? In complex tiebreaker cases like this, where two diagnoses equally meet the criteria, Guideline 2A basically says either can be sequenced first. It all depends on the circumstances of the admission, the therapy provided, and the specific chapter instructions. This is exactly where you, as the coder, have to play detective and dig deep into the H&P, the progress notes, and the discharge summary.
Because getting that primary driver wrong has devastating consequences. Assigning an incorrect principal diagnosis causes totally unjustified shifts in MDCs, which leads directly to immediate payer denials and massive revenue loss. Plus, if you consistently get this wrong, you're going to trigger severe compliance audit flags for either upcoding or undercoding, which completely tanks your hospital's case mix index and quality scores. Accuracy here isn't just about the money, guys. It's a huge compliance issue, and it's about accurately reflecting the true quality of patient care.
All right, Section 4. Let's summarize what we've learned and take a quick look ahead. To sum it all up, these are your golden rules. The freeze after study is your absolute North Star. It is never about the waiting room complaint. It is always about the final established condition. Your principal diagnosis completely dictates that base MDC and DRG grouping. So always prioritize definitive, clinically supported diagnoses over initial temporary symptoms. Follow those official guidelines strictly, especially for interconnected or probable conditions. And lastly, when the documentation is vague, accurate clinical documentation improvement, or CDI queries, are your absolute best friend to bridge that gap and land on the right code.
In our next explainer, Part 40, we're going to tackle the other side of this inpatient reimbursement equation. We'll be diving deep into secondary diagnoses, the incredibly complex logic behind complications and comorbidities, the CCs and MCCs, and exactly how exclusion lists can completely change your final DRG calculation. Trust me, you will not want to miss it.
So keep studying those guidelines and ask yourself this before our next class. If getting just one principal diagnosis code wrong can cost a hospital tens of thousands of dollars, what are the true financial stakes once we start adding in secondary diagnoses? We'll figure that out together next time. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. I'll see you in Part 40.